So now we will continue with our ECG mastery series, and today we will talk about the Q waves. If we remember from the first video that the Q wave is actually the negative deflection that precedes the R wave. So whenever you see the R wave, if there is a negative deflection before this R wave, this is called a Q wave. Okay. So what does the Q wave represent? It's actually representing the depolarization of the septum itself. So the electricity, guys, and please focus on this. So we have an AV node here, and there's bundle of Hess coming to the interventricular septum, and after that it will divide into left bundle and right bundle, right? Now, when the electricity comes into the interventricular septum first, the depolarization or the contraction as well will happen from the left side toward the right side. So the muscle of the septum will contract in a unique way in which the left side of it contracts first, and the electricity will just shift from the left side of the septum to the right of the septum. This electricity movement from the left to the right side of the septum will give me the Q wave. Usually the Q wave is a very tiny wave and is seen in most leads. Usually it is absent in V1, V2, and V3. And we can just justify this. Why? Because V1 is looking at the heart from here, 2 is looking here, and 3 is looking here. So they are looking actually into the septum itself. So they are directly looking at the septum. They will be unable to detect any movement in electricity. Again, to see any electrical current or the electrodes, for the electrode to detect any electrical current, this electrical current should move either toward this lead or away from this lead. So these three leads are looking directly perpendicular on the septum, and they will not see this movement. But if we go to V5 and V6, in which they are looking on lateral side from the heart, they will be perfectly seeing the Q wave, because the Q wave will be going the direction from the left to the right. So they will detect that, okay? So Q waves normally are not seen in V1, V2, V3. And if you see it there, it is pathological Q wave. Okay. The second point, that is absence of Q wave in V5 and V6 is most likely to be due to left bundle branch block. Again, how this could happen, let's see here. Now, let's say there is a left bundle branch block in which the left bundle is not working, it's blocked. So the electricity now will go to the right side first, and after that will go back to the left side. So there is no discrete depolarization of the septum. So these two leads here, the V5 and V6, will not be able to see any movement of the current inside the septum, because the electricity is already going to the right side before the left side. So there is no movement from the left side of the septum to the right side, and these two leads will not see current. So whenever you see an absence of a Q wave in V5 and V6, you have to think about left bundle branch block. This is important. Now, again, what is the normal Q wave? Actually, the Q wave is very unique. You have to know the abnormal Q wave in order to identify it much more. Again, if we can look at this ECG here, we can see this P mitral, in which the P wave width has increased, and that means there is left atrial enlargement, right? Now let's go back to pathological Q wave. When we can say that this Q wave is abnormal, first, if the width of it is more than one small square. Again, I will be using the small squares as my indicator. I will not use the milliseconds. So if the width of it, starting point to the ending point here, if it is more than one small square, this is abnormal. Look here, it's normal. The second one is if the depth of it is more than 2 small squares. So if I start from here to here, it's only one small square, so this is normal. If it is more than 2 small squares, it should be abnormal. The third one, which is really very important, it should be less than 25% of the depth of the QRS complex. If it is more than 25% of the depth of the QRS complex, it is abnormal. How we can determine that? So we get the highest point of the QRS complex to the lowest point of the QRS complex, and we calculate numbers of small squares. So they 1, 2, 3, 4, and we can calculate all of them to 12, approximately 12. So 25% of the 12 is actually 3. So if it is more than 3 small squares, this is abnormal. So in this case, it is normal, okay? So actually, this one is really very important. You have to know it. And the last pathological QF scenario, if you see it in V1, V2, V3, this is always pathological. Okay, so what does pathological QF indicate? If we see a pathological QF, what does that indicate? It indicates either a current MI, if the patient is having now a myocardial infarction or a previous myocardial infarction. And actually, you can differentiate between them. If the patient is currently having MI, usually there is an ST segment elevation as well. But if the patient has a previous MI, the ST segment will be normal, and you will see only the QFs. So QFs always means infarction. If you want to look for infarction, go and look for the QFs. Okay, let's get some examples here. All right. This lead is the AVF. I'm telling you that, guys, this is AVF. This is my isoelectric line, as we learned from the previous video. And we can just do this. Look here, there is ST segment elevation, right? And look for how deep is the Q wave. This is totally abnormal. So this indicates infarction, okay? And it's most likely to be a recent infarction because it's coming with, it's accompanied by an ST segment elevation. Okay, what about this one? Actually, this is lead 1, V1, sorry, not lead 1, it's V1. So if we see a Q wave, this is called QS. So we can see a Q wave here. This is totally abnormal. So this also indicates an infarction. If we get this line here, there is ST segment elevation, as we can see, and there is a QF. This is an acute MI as well. If the ST segment is normal, most likely this patient will have a previous MI because a QF is very pathological in these circumstances. All right,